into one and all. Intubation without muscle relaxants in cleft surgeries. Why to intubate without relaxant? Children with cleft lip and cleft palate have high association with complex syndromes, making the airway management difficult. Maintaining spontaneous respiration is advantageous. A. To evaluate intubating conditions of pediatric patients undergoing cleft surgeries without the use of muscle relaxants following induction with propofol and sevoflurane, keeping them spontaneously breathing. Based on the figures from previous studies, sample size was calculated to be 26, but we allocated 30 cases each in two groups, A group sevo, B propofol, using closed envelope technique. Basically, a randomized prospective comparative study was done in a duration of 1 year. Patients, including after taking informed consent from parents and approval from hospital ethical committee, included age group of 1 month to 3 years, patients undergoing cleft surgeries, both cleft lip and palate, and category ASA 1 and 2. We excluded parents who refused to take part in the study, and ASA 3 and 4, patients with upper respiratory tract infections within past 3 weeks. Method of conducting the study: after a thorough pre-anesthesia checkup, children were kept nil per oral for 6 hours, formula feeds and solids, and 4 hours breast milk, 2 hours clear fluids. To relieve separation anxiety, triclopyr 75 mg per kilogram body weight was given to children above 6 months, 1 hour prior to induction. Emla cream was applied to potential sites of venous cannulation 1 hour prior. After securing IV access and connecting pre-induction monitors like non-invasive blood pressure, pulse oximeter, electrocardiogram, injection midazolam 0.05 mg per kilogram, injection glycopyrrolate 10 microgram per kilogram, injection fentanyl 2 microgram per kilogram were given. Group A, sevoflurane was induced. Patients were induced with sevoflurane 8% in oxygen using a tight-fitting face mask and priming the Jackson-Rees circuit. After loss of eyelash reflex, intubated posterior pressure ventilation was commenced and threatened intubation was done at 150 seconds. Group B, IV propofol 3 mg per kilogram were given over a period of 30 seconds and intubation was attempted after 150 seconds. After confirmation of the interview position, injection atracurium 0.05 mg per kilogram was given and anesthesia was maintained with 2 liters of nitrous oxide, 1 liter oxygen, 1% isoflurane in the ratio of 60:40:1. EtCO2 was maintained between 30 to 35 mmHg, aiming a saturation of 90 to 100%. Observations made during the study. During laryngoscopy and intubation, the intubating anesthetist assessed each of the 5 variables: ease of laryngoscopy, position of vocal cords, degree of coughing, jaw relaxation, and limb movements were scored as per the scoring system shown in this table. A total score of 5 was considered excellent. Score of 5 to 10 was good. In general, less than or equal to 10 was acceptable and more than 10 was unacceptable for intubation. In patients of both groups, if 2 attempts of intubation was not possible, injection succinylcholine was given 1 mg per kilogram body weight and intubated. The demographic data were comparable in both groups, but they were not statistically significant. Both groups had equal distribution of cases for both cheloplasty and palatoplasty. The variables assessed was ease of laryngoscopy and degree of jaw relaxation. They were not statistically significant. Since open and moving position of vocal cords are considered acceptable for intubation, sevoflurane-induced patients had significantly better positions of vocal cords at intubation. Degree of coughing. Patients induced with propofol had significantly more cough episodes than patients induced with sevoflurane, which was statistically significant. Degree of limb movements. Patients observed significantly less number of patients had limb movements during intubation in induction with sevo compared to propofol group. Results: the intubation conditions are found to be excellent, 83.3% in sevo group and only 20% in propofol group. Majority of the patients in sevo group had significantly better intubating conditions, which was clinically accepted than propofol group. Use of sulfametonium, 1 patient in sevo group and 2 patients in propofol group, which was not statistically significant. So why to discussion? Why to intubate patients without relaxants? Children with cleft lip and palate are associated with retrognathia, micrognathia, glossoptosis, and laryngoscopy considered difficult in these cases. delay in intubation in an apneic child is risky. They are prone for rapid desaturation. Hence, it is wiser to keep the patient spontaneously breathing while securing the airway when difficult airway is anticipated. Succinylcholine, being an ideal drug of choice in difficult airway, is not always a better process. It has its own thorns. It can be fatal, especially in children with undiagnosed muscular dystrophies. Non-depressing neuromuscular blockers are less desirable in a difficult airway scenario due to prolonged neuromuscular blockade and unable to quickly reverse. Inhalation induction carry definitive advantage over intravenous induction because IV induction agents will have to get redistributed from the brain or get metabolized for awakening, whereas inhalation agents with low blood gas solubility provides rapid emergence. Limitation of my study, larger population could have been chosen for better and accurate interpretation of observation. Different dose regimes of induction agents could have been studied. So we conclude sevoflurane 8% in oxygen to be the ideal induction agent when muscle relaxants are not preferred in pediatric depth surgeries. Thank you.